last yeah, there we go. Last month and this month we are looking at outcomes, and that's always a difficult thing to really get a handle on when it comes to measuring outcomes and transformation, et cetera. So that alone was good enough reason to kind of jump into this. But I'm especially interested in this conversation because we are talking about the health system. And I have this sense that we're struggling more right now as a public health and health system, and kind of how we work together or don't work together. And it seemed to me at the point when we had the PDMP kind of a new issue, and that the primary problem was prescription drugs, there was more of a kind of a working together. It feels, at least to me, feels like less now, but I might be wrong. And I'm eager to hear, from our presenters today, how are things going with them. But that was one of the driving forces. And I think I had the name, I'm forgetting now the name of the webinar, but it was something about this disconnect or whatever. But anyway, there you have it. Here's your intro.
Well then, without further ado, we'll jump into our first presenter. So joining us is going to be Sarah, coming from also from Michigan. But Sarah, I'll let you go ahead and introduce yourself.
Sure. As Chris said, my name is Sarah. I am coming to you from Michigan, from a group called Open. You might have heard of it before as Michigan Open. We're kind of going through a rebranding. So, but our group is focused on opioid prescribing and engagement, and acute care pain management. I am a nurse by training, and I work with Open as a clinical implementation specialist, so helping hospitals with their quality improvement work, and specifically around pain management practices and getting better care for our patients. So I will share my screen here. You guys can just give me the thumbs up that it looks good. Okay, cool. So I was asked today to talk about our academic detailing program that we've been working on over I'm trying to remember when it actually started. I know over the last year. I was new to Open in June. So I am getting up to speed and all of that good stuff. But our team has been working really hard on it, and we are getting excited for the evaluation piece. And so today we will talk a little bit about that. And there we go. Okay, so our academic detailing program is kind of a partnership among three groups, one being Open, two is Alosa Health, which they are one of the originators of this academic detailing concept, which was really born out of the pharmaceutical industry. And then the third piece of our partnership for this project is a group called BMC2. And they are a collaborative quality initiative in Michigan. There's a group of, they're called CQIs is the acronym for them, but they are sponsored by Blue Cross Blue Shield in many different specialties, and they focus on quality improvement and really just all the hospitals in Michigan, or as many as we can get for each of the collaboratives, but focusing on working together to improve patient care. One of those groups is BMC2, which they're focused on vascular surgery and PCI procedures. So the focus for our academic detailing is vascular surgeons, providers in that specialty. We leverage this CQI structure that they already have set up. They already have good networks established within the hospitals. And so we recruited vascular surgeons to participate in our academic detailing program focused on appropriate opioid prescribing and pain management. So before I talk to you about the evaluation, I have to talk to you about challenges, because in all honesty, we have not actually had our first academic detailing session get off the ground yet. We have spent the last bit of time working through what is the session going to look like, recruitment, development of materials, and making sure that we're really on the same page with Alosa Health, who's kind of the like vendor, if you will, for the academic detailing part. So the academic detailer is hired by Alosa Health. And so our challenges have really been around getting providers to follow through with participating in the sessions. We had great recruitment, great interest, but getting time on their calendars, getting a response to an email, etc., has been a bit challenging, as I'm sure you can imagine. This focus on surgeries, a little bit, to my understanding, is kind of newer for academic detailing. The previous like specialties that it seemed like Alosa was most familiar with was more in like primary care, dentistry, things where people maybe go to, you know, the same office every day or have a bit more of a predictable schedule. Whereas surgeons are kind of all over, whether they're in the OR or the clinic or offsite. So it's just harder to get, you can't go wait for them somewhere. You're not quite sure where they're going to be that day. So that is all to say, we are working very hard to get our first session, and we have it scheduled. It is this week, actually. So hopefully next time we talk, we'll have more details on how, you know, the outcomes of our evaluation. But our plan for evaluating is really through quantitative and qualitative data analysis. We are unique and lucky in that we have a couple different quantitative data sources that we will be able to work with. We have opioid prescribing data that will come through the BMC2, which they collect lots of data on the patient level, and some of that is opioid prescribing. So we'll be able to see, for those who have went through the academic detailing sessions, how are they doing with compliance with the open prescribing recommendations for appropriate patients. We also have a unique DUA with the state of Michigan, so we can access PDMP data, and we'll be able to also link that with the patient level data that we get through BMC2. So we can see who received prescriptions but didn't actually fill one. We can look and evaluate for refills, and see if anyone has developed any new persistent opioid use after surgery. The other piece of the puzzle for evaluation, like I said, is qualitative analysis. So we will partner with Alosa Health to gather feedback from the providers that have completed their academic detailing sessions through an evaluation form. And then on the open side of things, we also will conduct some qualitative interviews and analysis to see, you know, how we can improve our sessions going forward, kind of what were the outcomes. And then maybe if we can get participants who didn't actually do a session, we can figure out what might be a good recruitment strategy going forward, what kind of prohibited them from participating in an academic detailing session. And then to end on a high note, some of our successes. So we have had, it's been a lot of work, but we've had a good partnership between three decently, sized organizations. We've been able to fully develop this academic detailing program for vascular surgery. We recruited surgeons well. We had a good number of interest. It's just getting that appointment on the calendar, and we had kind of a lag time between when we launched and when we were ready, when Alosa was ready to start scheduling sessions. So I think that's kind of the battle we're in right now. And I think our strategies for evaluation will be great and prove to be sound, but we just got to get our sessions off the ground, and we can report back on that after. So that's all I have for today. If anyone, I don't know, Jan and Chris, if you want me to take questions now, if anyone has them, or wrap up, but this is the QR code to our website. We have lots of patient materials, provider facing materials, so feel free to check us out.
I think what we'll do is maybe since we have so many presentations, we'll just wait until the end and then have kind of like group questions. But if anybody has any quick questions, I guess we can take one or two before we jump in. I saw a couple fly through in the chat, but it looks like we had some chat responses come in to follow up on those. Awesome. All right. So yeah, what we'll do is if you have questions for Sarah or any of our panelists today, just go ahead and write them down, jot them down, either share them in the chat or otherwise we can take them all together at the end. And Allison, take it away. I see you're already going with the shared screen. You're on the ball, Allison, as usual.
Thank you. Let's see. Hi, everybody. My name is Allison Gunn, and I work in the North Carolina Division of Public Health in the Injury and Violence Prevention branch. So we'll talk about the work that we're doing for Strategy 7, which again is focused on guideline implementation, clinical education, and training. So the things overall that we're trying to do are sort of to use the information and the guidelines from CDC to get that out into our to our healthcare providers, and we also do some academic detailing. We collect some feedback reports from our provider projects that we're doing. We, of course, encourage and we provide some training on safer prescribing practices, and we have a couple of projects with emergency departments. And we do try to do a bit with insurers and health system support. So I'll mention a bit of that as we go on. So this is a depiction of our North Carolina Opioid and Substance Use Action Plan. And I'm just curious if folks know if your state also has an action plan. And, you know, this is something that we've done. Yeah, it looks like some folks are nodding. Our action plan has 3 guiding principles, which are prevention, reducing harm, and connecting people to care. And so we'll talk about how Strategy 7 fits into our action plan. Essentially, what we have done is really contracted out to some key education providers and key entities within the state. And that includes what we call our Mountain Area Health Education Center, MAHEC. We have a Governor's Institute, which provides training and educational support to medical entities within the state. We have the North Carolina Healthcare Foundation, which also does that. And we partner often with the UNC School of Medicine to also provide some training. Excuse me. So for the Mountain Area Health Education Center, we contract with them to provide trainings on MAT, to provide MAT waivers, to do all sorts of training for people, clinicians, healthcare providers across the state on a variety of topics, some of which I've included here in this slide. So everything from MAT to promoting equity in the treatment of substance use disorder. And we often offer technical assistance to those entities that are providing training across the state. And it's really variable in what format it comes. It can be to physician's assistants, to medical doctors, internists, residents, everything. And over the past couple of years, we have been able to collect data, some progress reports from the Mountain Area Health Education Center, and they have let us know how many providers they've trained, and we're in the process of still crunching the year 4 data. So, you know, or rather the year 3 data. So we're not sure what that number will be, but we anticipate that as time goes on, we're continuing to provide training to a lot of different clinicians across the state. And this is just a graphic display of North Carolina and the trainings that have occurred, or the number of, rather the folks who've been trained across the state, what counties they focused in. And in fact, you can see they're mostly focused in the western part. That's in part because we collaborate. Again, the Mountain Area Health Education Center focuses on the western part of the state of North Carolina. And in addition to the trainings that we do for students, residents, interns, nurse practitioners, we also provide some academic detailing. And we, again, like the presenter before me, we also contract that out. So this slide just depicts some of the number of providers who've expressed interest in academic detailing. And then at the time that this slide was created, which was a little bit ago, I have to look at the updated numbers for this, but 6 providers had completed academic detailings. And then we also work with the Governor's Institute, and the point of that is to also train clinicians on the identification, prevention, and treatment of substance use disorder. So we have a number of methods that we use to train people. In this instance, with the Governor's Institute, they create a lot of videos, and they also present at conferences to that include, you know, CEUs, continuing education credits, and that type of thing. So we have had a lot of success with partnering with the Governor's Institute, and they just reach, you know, they really expand across the state. Their reach is large and long, so that's good for us. We also partner with the North Carolina Association of Pharmacists through the Governor's Institute, and so these include trainings on harm reduction services, collaborative MAT pilots going on across the state, pharmacy-focused videos are being developed, local harm reduction seminars for pharmacists or pharmacists in training, and then county-specific resource cards. So we created these cards that we distribute to pharmacies across North Carolina, and on those cards they have connections to care that are specific to that county. And we also partner with the UNC School of Medicine. We have a couple of pilot projects with the UNC School of Medicine that focus on providing linkages to care and harm reduction resources for people who've been hospitalized with infections that are caused by intravenous drug use. So at the time this slide was created, we had approximately 80 patients who had engaged since the start of the project. And then we partner with the North Carolina Healthcare Foundation to also conduct some pilot programs across the state that look at opioid prescribing practices and how pharmacies are adhering to clinical guidelines for opioid prescribing practices, and also educating pharmacies on the best practices for opioid prescribing. And then lastly, we also do a lot where we expand access to naloxone across the state. And I included that here because, of course, MAT waiver is included in Strategy 7. So for North Carolina, let's see. Slides are jumping too fast. We were able to purchase naloxone, not through CDC funds, obviously, but through our partnership with the Division of Mental Health. And so we consider that a success, although, again, we do not use CDC funds to purchase naloxone, but we count that as one of the initiatives under Strategy 7. And then we have we try to track and coordinate the distribution of naloxone. It's a little bit iffy, so we've created a survey that we distribute to all our partners across the state, asking them to track the distribution of naloxone and any reversals that they've recorded. So this information is a little variable because not everybody completes the survey, not everybody does it in a timely manner. So the data is a little muddy at this point, but it gives us a snapshot of what's occurring across the state. And it allows us to know how many folks are distributing naloxone, how much naloxone is being distributed, and any reversals that they've recorded. And that's all I have for today.
Awesome. Thank you, Allison.
Hmm.
Let's see. Daniel, are you here? If you are, can you come off of mute or jump on the camera? All right. So we may be one presenter down. So Todd, this leaves it up to you to jump in right now in slot number 3.
I am ready.
But you know, this creates a little bit more time for questions at the end too. So that's good too. But go ahead, take it away, Todd, when you are ready.
Thanks, Chris. I am part of the Illinois evaluation team on our overdose data to action project. My name is Todd Lee. I'm a professor in the Department of Pharmacy Systems, Outcomes, and Policy at the College of Pharmacy at the University of Illinois, Chicago. I co-lead our evaluation activities with my colleague Simon Picard. I'm going to take a slightly different tact than Sarah and Allison took, and I'm going to dive specifically into one element of what we're doing under strategy 7, and I show you some of what we've done from an evaluation side. This work is related to our naloxone outreach work directly to community pharmacies. The state of Illinois has a naloxone standing order where community pharmacies are able to dispense naloxone without a prescription from a prescriber. And we have implemented some educational outreach programs and evaluated those educational outreach programs as part of our Strategy 7 activities. To give you some context on what we've done thus far, in 2021, we were able to recruit and train 6 student pharmacists, so students in our College of Pharmacy that we were going to have in the field in sort of an academic detailing or academic detailing light, almost educational outreach capacity. We use a train the trainer model where we've have a number of folks who've gone through NARCAD's academic detailer training and have trained academic detailers in the past to get our detailers up to speed on the work that they were going to be doing in terms of the naloxone standing order, how to have conversations with community pharmacists about stigma associated with naloxone dispensing, and a number of other factors. Our goal was to do outreach to more than 300 community pharmacies, largely in the northern Illinois region, and I'll show you on a photo or on the map where we've done outreach activities to thus far. Based on sort of a convenience sampling approach, what pharmacies were available and around in terms of us doing our outreach to them. We drop in unannounced. We had initially implemented this as a web-based opt-in outreach activity, but we couldn't get lots of participation and transitioned to unannounced drop-ins to community pharmacies where our educators will go in and ask to speak to a pharmacist and then have a tailored 10 to 15 minute conversation with them about what they know about the naloxone standing order, and really trying to get a better sense of some of the barriers that exist to the dispensing of naloxone via the state of Illinois standing order. And we capture data through a couple of primary mechanisms. Most of our data are coming directly from our detailers, where after each one of the visits, they complete an online survey tool that asks them to fill out a survey instrument, which I'll talk about a little later in the slide, and I'll show you what that instrument includes on the next graphic. We ask them to specifically ask pharmacists about barriers that they experienced in naloxone dispensing, and those are captured by the detailers in their notes following the visits. The instrument that I was alluding to is called the DAVE, the Detailer Assessment of Visit Effectiveness, which is a validated instrument that we had developed as part of our Prevention for States funding, actually, when we had done some provider-focused academic detailing around opioid use. We have a companion instrument to the DAVE called the PSAD, which I won't talk about because that's a provider filled out. That's a provider satisfaction of academic detailing is the name of the full name of the instrument, but that's a provider completed tool, which we did not have pharmacists complete as part of this activity. Just to give you a sense of what's in the DAVE, it's a 5-item instrument that's intended to capture constructs around usefulness, relevance, acceptability, feasibility, and communication of the visit. Items 1 through 3 in our factor analysis sort of load together, so we create a summary score around those 3 factors. And we use this to make comparisons across our detailers to see if there are any differences by detailer, but more importantly, we do it across types of community pharmacies. And I'll show you in a table coming up how independent community pharmacies compare to sort of the chain or drugstore community pharmacies versus community pharmacies that are in large box stores, grocery stores. So we make contrasts across each of those 3 groups. The data that I'm going to share with you over the next couple of slides were collected, as I said, last spring and through the fall of 2021. Drugstores are classified into 3 groups, as I indicated, and I'll walk you through our attrition chart, but we ultimately got rid of our visits that occurred virtually and then where we're unable to collect some data. So let me show you how we've identified the groups of pharmacies that we include in the analysis that I'm going to share with you today. So we hit almost 360 pharmacies over that time period. Ultimately, 73 of those visits were failures in that the pharmacist did not want to or did not have time to have a conversation with our academic detailer. 10 of the visits were early in our initiative, and we excluded those because they were virtual. It leaves us with 276 core visits to work with. Ultimately, there was a problem with the data in 6 of those visits, and our capture of the data on what the detailers provided. So we're working off a final sample of 270 visits that were evaluating the barriers to naloxone dispensing via the standing order. Here's the map that I promised. If you're familiar with the geography of Illinois, this is really the top quarter of the state that I've got highlighted here, and the red dots represent the locations of the pharmacies that we did outreach to over this time period. So here's a quick snapshot of the characteristics of those pharmacies and whether or not there were differences across the types of pharmacies. And I'll just highlight a few things that I've drawn your attention to in the blue boxes. The first was whether or not they stocked naloxone. You can see that a lower proportion of the independent community pharmacies, 30% of them stocked naloxone relative to the drugstore and the grocery or big box pharmacies. And then there was also some difference in their comfort dispensing naloxone across the categories of pharmacy type, and whether or not they reported barriers. In fact, the independent pharmacies were more likely to have problems or report barriers than were the drugstore or grocery pharmacies. And I'm going to dive into what those barriers were that we were able to identify through our outreach activities. This pie chart, I probably should have used some different colors, but just to orient you to how it works, we'll start with the biggest slice, this 28%, and the categories go across in the row, and then they move down to the next row. So this is cost, this is patient stigma, this is an other category where things grouped together, the patient not being interested. So the more than 50% of the barriers that were identified through our outreach work were associated with the cost or problems with insurance and patient stigma. And just to put a little more context around that, especially as it relates to the independent pharmacies, the message that we heard loud and clear was this is sometimes a bad financial decision for them to dispense naloxone via the standing order, because their acquisition costs were actually higher than what they were reimbursed when they dispensed the medication. So it was a money losing effort if they would have decided to participate in this activity. Oh, I'm sorry, I'm going the wrong way. Let me provide a little breakdown of the kinds of barriers that were reported by type of pharmacy. And again, I'll pull your attention to the two blue boxes on the screen and note that there were certainly differences between independents and the non-independent pharmacies in terms of patient stigma being a barrier. The drugstore and grocery pharmacies were more likely to report patient stigma as a barrier than independent pharmacies were. And then there is a vast difference in enrollment in the standing order, where all of our drugstore and grocery pharmacies were enrolled in the state of Illinois standing order, whereas almost half of the independents were not enrolled in the state of Illinois' standing order for naloxone. When we look at the DAVE, we also found some differences across the different types of pharmacies. I've highlighted the scale summary score, which is again the first three items together, and the assessment of visit effectiveness was lower for independent pharmacies than it was for drugstore and grocery pharmacies, as evaluated by our detailers in that summary score, and across the individual items within the DAVE. So what now? Now what? So based on what we learned in our evaluation activities for that 2021 work, we've made some modifications for 2022. Because of the challenges that we heard from our independent community-based pharmacies, we wanted to arm our detailers with more information about naloxone access sites that weren't only through pharmacies. So when pharmacies chose not to participate in the standing order for Illinois, we wanted to allow them to have conversations with patients or individuals that were seeking naloxone, to be able to have resources to know where to send them or refer them in order for them to be able to get naloxone. We've expanded outside of Northern Illinois. Illinois, again, if you're familiar with the geography, it's a very tall state. We need to get further south and expand outside of the Chicago metro Northern Illinois region, because we feel like some of the barriers being experienced by community pharmacies outside of that region might be different and important for us to identify. We also have made a focused effort to reach out to more independent community pharmacies because of the differences in the barriers that were identified between those two groups. We're currently in the process of making some comparisons across the qualitative data that we've collected in 2021 and 2022, and the DAVE that we've collected in 2021 and 2022, to see if there are differences. We're not as keen or as eager to compare naloxone dispensing. We do have that available through our relationship with the prescription monitoring program, but we feel like there's just so much happening around the Illinois standing order and naloxone dispensing that it's certainly going to be more than the effect of our academic outreach program that modifies naloxone dispensing. We will eventually examine it, but it's not been a priority for us. And I guess just as my final slide, the green are the visits that we've collected in 2022. And we have been able to sort of move out of the Chicago region. We're up to 220 some visits for this calendar year. So we've visited over more than 500 pharmacies over the last year and a half period in terms of our outreach program. And with that, I will stop sharing and be happy to take questions with the rest of the group.
Awesome. Thank you so much, Todd. And as we head into our Q&A portion of the day, I'm just going to reach out. Daniel, are you there? I don't think so, but okay. As we head into our Q&A portion, I'm going to turn the moderation of this one over to my colleague, Jan, to lead the questioning. Questioning, it sounds so.
Yeah, for sure.
Yeah, go for it, Jan.
Yeah, that was a nice variety. of looks at outcomes and working with health systems. I was wondering, Todd, you had a couple things that you had said. You saw increased stigma with the grocery, I think you called them grocery drugstore
Yeah.
pharmacists. I'm wondering why you think that might be the case. And then I think with the independent pharmacists, you had a lower score. I think with the Dave piece. Did you
Yeah.
guys kind of think
So
about that?
I'll speculate on both those things, and I think I have pretty good answers to both of them, Jan. At least what we've talked about within our group is the reason that we believe we're seeing patient stigma as less of an issue among independent pharmacies and higher in those grocery store and classic drugstore pharmacies is because of the relationship that independent pharmacists have with their patients. They're more likely to know their patients and their population than the pharmacist at Target or CVS or Walgreens. Not that they're exclusive to those three groups, but those kinds of pharmacists. So I think that's probably why we are seeing that difference in patient stigma being less of a barrier amongst the independent community pharmacies.
Yeah, makes sense.
The Dave element is probably related to sort of their overall buy-in to the Illinois standing order, and that they're just a little more resistant. So the detailers don't perceive their conversations as being as effective as they are with the other pharmacy types. When there's more buy-in to the topic that they're talking about, they're more likely to endorse higher levels on our scale around satisfaction and communication and those kinds of things. So that's my hunch as to why we're seeing the lower Dave scores amongst the independent pharmacies.
Yeah, that has face validity for me. I like those explanations. Does anybody else have some questions that came up as you were listening? Other stuff that crossed your mind? No?
Jan,
Okay.
before I was just going to say, I'll put a plug out. I included on the slide where you can get the Dave. You can also get the PSAD, the provider satisfaction for academic detailing instrument, is also available on that same website. Both of these are validated instruments for use in academic detailing that we developed as part of our, again, Prevention for States funding, completely free to use on an academic basis. You can get them off of that website, and I'd advocate, if you're interested, take a look. I think they're hopefully good, consistent. If we use them more in our academic detailing work, we'll have more of a sense of the bang for the buck that we're getting.
Yeah, I like that. That's going to be helpful.
We have a question, and this one is for Todd. How would you amend the standing order? Are there ways it was written that discourages access to naloxone?
Fantastic question. I actually don't think it's the way the standing order is written. I think it's the way that pharmacies have opted to implement the process. So what we've learned is that through some of the larger drugstore kind of pharmacies, there are some barriers in place because of process requirements for dispensing naloxone around documentation and things that they're required to do that were not intended to be done as part of the original standing order. The community pharmacy barriers are really around financial issues. So I don't think it has anything to do with rewriting the standing order itself. It's more policy issues around how can we make naloxone available to independent community pharmacies, either at a lower cost, so they're not losing money when they dispense it, or improve their reimbursement rates. And that's sort of beyond the capacity of the standing order to sort of modify those things. It's from the state's perspective, that's a legislative issue related to the Medicaid program that would probably have to be undertaken.
Yeah. We're kind of thinking in those terms too. We're feeling that there's a need at this point for some sort of policy change, and we're hoping that the data that we're gathering is going to be, help us to advocate for that. Well, we don't really advocate with the legislature, but to kind of persuade them.
Jan, we're doing something similar. We've shared the barriers stuff with the PMP, obviously, as part of the work that we do, and talked with them about doing outreach around the cost challenges associated with naloxone dispensing. It's important, and there's new legislation that came out in Illinois that will be enacted at the first of the year that requires pharmacists to offer naloxone every time there's an opioid prescription dispensed. And unless there's really changes in the financial structure for these independent community pharmacies, that offering is only going to be just, hey, would you like this? And not really trying to deliver on making it available.
Yeah, for sure. Thank you. Hey, Sarah, I had a question for you about working with Alosa.
Sure.
What was that? What is that like? I mean, they're kind of a big player. I imagine that they have certain ways of thinking that is great because, they've been through this many times, especially with outcome sorts of things. But there are probably times where you probably had to kind of work with them to get on the same page. What was that
Mhm.
like?
Yeah, definitely. So I think it is really helpful that they have a lot of experience in this area, and it's the academic detailer that we've been assigned, who was hired by Alosa, seems really great and phenomenal to work with. So I look forward to continue working with him. I think one of the more challenging pieces, and the part that has taken a little longer than expected, is trying to mesh together what we have already developed from open. I mean, we have lots of materials and resources and prescribing recommendations, that kind of thing, and lots of experience in the surgery world, but we don't carry that academic detailing expertise like they do. So it just took some time to mesh kind of what they have and envision for academic detailing with what we have as open, and present a united front, if you will, when the academic detailer is out at these hospitals representing really 3 different organizations.
True.
So we had to be really thoughtful about that.
Yeah.
And that's
Yeah.
what took a lot of time. Between we had a lot of interest, and then we had this lag, and then we were finally ready to set up the sessions. And so we just kind of got to get some more energy back around it, which we have plans to do. And are working on. But yeah, I think overall good, but just some bumps to work through, which I think are expected as we are getting into a new area with surgery.
I thought it was interesting that with all their experience with academic detailing, they were not that familiar with surgeons.
No, I did not get the sense, and I could be completely wrong, but that's not the feeling that I got. And when Todd had mentioned about, the unannounced visits that they started doing, I know that is kind of also Alosa's go-to, and it just doesn't work for surgery.
No.
You can't show up in the OR.
Yeah, they're just all over.
So yeah, so it's just not, and we're also working through another group's kind of contacts, if you will. So we got to be respectful of that, and have to manage that partnership carefully too. So unfortunately, the unannounced thing doesn't work as well in this setting. And so I think it took them a while to figure out that that's not going to work.
Yeah. But I imagine once things get rolling,
Oh yeah,
you'll be clicking after that.
yeah. They have, like I said, our first session is the 19th, and then the BMC2, which is the vascular surgery collaborative that we're working with on the hospital side, to recruit surgeons. They have a big meeting also in November. And so their plan is to have that surgeon give kind of a personal experience sort of thing, to help gain some traction around it. And then their leadership will also continue to get involved. So I think we're getting somewhere. And we actually had some ortho interests too. So I think we're, once we get it started, we'll be good.
Yeah, if you can work with those ortho guys, that's pretty good.
Oh man.
They're like cowboys.
Yeah.
No, I know it's a stereotype.
It's tough. Mhm.
Are there other questions? I had another question for Allison. What I liked about your presentation, Allison, is that you're really making use of all these different partnerships, which, as I said at the beginning, I'm feeling like I'm a little estranged, from health systems, but I think working through those partnerships is kind of a way to do that. That's been a kind of a key way for you to work with health systems, it seems like. Is that
Oh,
true?
definitely. Yeah. I mean, again, what I like about OD2A is like it really does try to address all levels of the social ecological model, in my opinion, because it does try to get it like, yeah, you're trying to focus on policy and you're trying to focus on providers and prescribers and pharmacists, and then all the way down to, people in the community and local health departments and like coalitions and everything like that. So without these sort of champions for these organizations, these partners who work with clinicians, or again, the education component, so just getting folks who are professors, so not just clinicians in the field, but like people who are training future clinicians and pharmacists. That's been really key. And then North Carolina's got so many great schools of medicine already, and so it's like they all have like governing entities and institutes and governing bodies, so we try to leverage those partnerships as well, so that we can get in the door and say, like, oh, is this is MAT, is the need for MAT being taught anywhere, is there training being provided, is there MAT waiver training being provided, prescribing best practices, is that being taught, where is it being taught, or are there pilot programs across the state? So yeah, those partnerships are key. Otherwise, I don't think we could do this work, quite frankly.
Yeah.
We work at the local, in our office in the injury and violence prevention branch within the Division of Public Health. We definitely work more closely with local health departments, and so yeah, without that going up the social ecological model, I don't think we could do that without these partnerships, for sure.
Yeah, for sure. That's definitely a take home for me from, listening to you, that I kind of want, with my team, talk more about how can we establish, more and better partners, especially in the health systems area.
One of the things I think is unique is we actually have a pharmacist who works for us in our branch. And so she is our connection to all of these partners. So she does work, well, I'm not sure if she currently is. At one point she was working part-time as a pharmacist, and then the rest of the time working for us. And so she's really able to bridge, she's the contact with all of these agencies and governing bodies and these programs across the state. And she speaks that language and she knows the players. And so having her on our team has been totally fundamental to making these partnerships work.
Yeah, I can see that. Cool, thank you.
Yeah, thank you.
Some other questions that people might have out there, some thoughts, some things that you're doing perhaps. I did like that little graphic you had too, Allison, for your action plan. That kind of makes me want to do that too. So
well, I am curious, does everybody is like, probably, I know Todd nodded his head, but every state has an action plan, is that right? Or doesn't, maybe they don't?
we have a strategy. I don't know, but I liked how you kind of put it all into a particular, like a graph, and it had everything kind of played off of each other.
Yeah, and it actually does interplay well with the 10 strategies from OD2A. So, they are all focused on like prevention, connecting people to care, linkages to care, harm reduction. So they definitely reflect each other.
Yeah.
But yeah, we use those to guide all of our work.
Yeah, does anybody else have something like that, where your action plan is kind of laid out that way, that we can sort of at a glance see?
We don't have the same exact kind of graphic in Illinois that Allison was talking about. However, there's a ton of overlap between the OD2A strategies and what's in the action plan itself.
Yeah, cool. other people or any other questions that you might have? I think there's a lot of good stuff here. Chris, I think that might be it though.
I do believe you're right. I want to thank everyone for joining us. Thank you,
Yeah.
Todd, Allison, and Sarah, and for everyone else who's joining us here today. As per usual, I saw a couple of people ask, but we will have the recording of this down and up on our site as soon as I can get that together. You'll find all of our recordings at evaluation.od2a.org. Just a little preview next in a couple of weeks. So we have our email that goes out. There's going to be a new one in a couple of weeks, and in that one, we will share Jan's first podcast where he is talking to one of our members about her work. So I'm just a little preview that's coming. I also wanted to put that out because it will make me go into editing mode and make sure it gets out by
Sure.
2 weeks from now. So I've made it public, so that will happen. And if anyone has any resources they want to share, one of the things we want to do with our bi-weekly or bi-monthly newsletter is to share out resources that our community members are sharing or creating for their own jurisdictions or creating for their own selves, papers, blog posts, news article, other things that they want to share. If there's anything you want to share with the community, definitely reach out to me and I would love to hear about them. My email is admin@evaluation.od2a.org. With that said, I hope you all have a great week and a fantastic Halloween when that comes. And we will talk soon. All right.
Yes.
Bye, everyone.
Thanks, everybody. Thanks, Todd, Allison, Sarah. Talk to y'all later.